Today we're going to talk about an interview study that we did with medical device manufacturer security experts. And first of all, let's just start. Why do we care about this problem? So we will have some headlines, unlike the last talk, why we're dealing with this today. And I'd be remiss if I didn't start with a shout out to Kevin Fu, who kind of pioneered this whole area in 2008, found some of the first vulnerabilities in medical devices, but they haven't gone away. We saw in 2019, insulin pumps had to be recalled because of a cybersecurity issue, which was the first time that ever happened. And this still continues today. And a more boring technology, pneumatic tubes, was found to have vulnerabilities. And 80% of major US hospitals use these things. And basically they are what get your blood, your samples all across hospitals. And so if those things go down, the hospital goes down. So medical device regulators around the world are thinking about how do we actually create secure medical devices. And the FDA is one of the pioneers in this, but a lot of the other regulators are also following the similar track. And they are encouraging this process of threat modeling, designing secure devices, not bolting on security, but instead having it from the get-go. And so for the purposes of this talk, we're actually going to use the FDA's definition to help guide us with threat modeling. So this process for identifying security objectives, risks and vulnerabilities, and then defining those countermeasures to prevent and mitigate the effects of these threats. The FDA and medical regulators aren't the only ones who are promoting threat modeling. So CISA, along with 19 other global regulatory agencies, have put out this Secure by Design framework where they do also recommend threat modeling. So generally, threat modeling is something that we do want to understand better. And there hasn't been a ton of work that focuses exactly on how practitioners think about it. And instead, it's about proposing more novel methods. So we wanted to kind of take a step back and think about what do practitioners actually do. And so we focus specifically on medical device manufacturers because they're a great population. They have to do this, so they're very incentivized. And they have a little bit more training and things along those lines in a formal way. So we wanted to answer two questions. The first is, how do they actually identify specific threats in the system? How do they think about the mitigations? Then we wanted to say, what are the process in which they actually navigate through the threat model? How do they actually go through the system's design to find the threats? So as I said, we did an interview study. As I learned yesterday, probably 60 minutes was a little too long to get practitioners. 30 minutes was the recommendation. But we did worked where we did a screening survey initially, and then we did an interview first talking about the participants' background a little bit, and then we gave them two scenarios in which we asked them to think about what threats they might see to the system, how they might mitigate those threats, and kind of what they're thinking about when they're looking at these types of issues. So with that, what are these scenarios? Where did you come up with them? So we sat down with a bunch of experts who have actually built, regulated medical devices and crafted a series of 3 scenarios that represent real-world devices that are deployed today. So the first was a robotical surgical system. And so this is something that would be found in the hospital. And it would lead to potentially patient death if this thing was exploited. Then we also looked at a next-gen sequencer. These are things that are used to sequence DNA to sort of get an understanding of what actually exists there. This was huge during the COVID-19, actually, for instance, where they were looking at these types of, using these types of systems. And here, this is found in a laboratory setting, so not the hospital. And the worst case sort of scenario, in many cases, would just be a potential misdiagnosis or also potentially some privacy violations. And then the last is an artificial pancreas. So this consists of an insulin pump as well as a continuous glucose monitor, which is implanted on the patient. And so they are walking around with this device daily in order to use it. And again, similar to the first scenario, this could lead to potential patient death. So to kind of give you a sense of what we actually gave participants, we included a set of requirements, a high-level context diagram, and this is what we have here for the robotic surgical system, as well as a more specific data flow diagram. So for this system, we thought about, all right, you should be allowed to have remote surgery. This is something that is able to be done today. So we have this surgical cart where the patient's being operated on, and then a surgeon on a remote console somewhere else. We also wanted to have the reports from the surgery be able to be synced to the hospital servers, to electronic health records, so those are maintained there. The ability for the life support monitoring equipment, which might come from a different manufacturer, to also be sent to patient vitals, et cetera, to be sent to the surgeon. And then finally, to allow for observers who might be able to watch the surgery, including from the surgeon's viewpoint. So a great thing for medical students, for instance, to learn. So before I dive into actually the results and our sample, I want to talk about recruitment. So recruiting in this population is very difficult. In addition to my own experience working, consulting for medical device manufacturers in security, we also went to a number of different conferences, engaged with the community over a process of 2 years in order to actually conduct this study. So we interviewed 12 experts who are involved in securing medical devices. We found that we had about even split between if you started your career in medical devices or if you started your career in security, and then obviously transition into specifically focusing on security for medical devices. And the participants came from a number of different types of organizations. So we had representation from within the top 5 global manufacturers, as well as more specialized folks and those who were consulting for medical device manufacturers on security, many of whom had prior experience working there. Additionally, our participants ranged in experience, but we definitely skewed towards more experienced. We found that the less experienced folks were more willing, they wanted to defer to their more experienced peers instead of feeling comfortable with threat modeling themselves. And so note that 75% of our participants had more than 10 years of experience. So our results consisted of 3 major findings. The first is that there is this flexible process for brainstorming threats and controls. Then safety considerations are very critical, but the integration of this is really unclear. And so kind of heard a little bit about this during the keynote, but really want to emphasize this idea that security community cannot run away from safety. We need to think about safety in these processes. And then finally, this idea of ad hoc navigation. So how do they actually work their way through the threat model and their use of use cases, which is a thing that hasn't ever been discussed before with threat modeling in formalized methods. So first, we're going to focus on this idea of the flexible process. So when we talk about the way that they think about these things, and as we said, like this linear structured approach, we think about what are we building, what could go wrong, what are we going to do about it, did we do a good enough job? And so this is built from the 4-question framework, which was developed by Adam Shostak, who's a pioneer in the field of threat modeling, as well as a bunch of other industry folks have created this within what's called the Threat Modeling Manifesto. So within that, though, there's some other specific implicit and explicit questions that are being asked. So, what are the threats that might exist? What are the security property I'm thinking about? What are the safety impacts specifically for medical devices? And then, what are the mitigations? What are the different ways that the system might be configured depending on my customers and their use cases and their needs? So when we were thinking about a particular component of a system, they're not necessarily starting out always with what is the threat that I need to be worried about. It's instead could be a different set of these questions. It could be, what are the mitigations that I need to consider? Or maybe if I've already built the system, what have I already built? It could also be, what are the threats that exist? What are the security properties that were being addressed? And again, the safety impacts. And this is interesting because it is in line with prior work that has looked at assumptions in threat modeling, and so these implicit and explicit questions that people are asking. So an example of how this might look is you could start off with one question, such as, what security properties am I addressing? So this participant talked about, well, I'm looking at the integrity of the data, and then the availability, and then how that affects the harm to the patient. And so that links on to that next question of what's the safety impact. But you also may revisit to the same question to really think about what are the different options available to me for this mitigation, for this system to mitigate. So in this case, the participant talked about separate VLAN, having individual access or role-based access as well for this particular part of the system. So with that, what are the safety considerations? So one of the interesting things is that a lot of standards talk about having separate processes between safety and security, and it becomes the elephant in the room for a lot of these types of security problems, because we say, all right, well, when I say, all right, I want to go harden the system, so in this example from this participant, you can't just do that. It's not as simple as that because it has potential to have effects on the clinical workflows. So we need to make sure that we're thinking about, does this impact the safety? Does this impact the clinical efficacy of this device? If the device is no longer efficacious, who cares? Why are we using it? Additionally, this idea from another participant was talking about, we have these separate processes. We do sync, but there is miscommunication that it can occur. When you say likelihood to a safety-focused person, they think in probability, and yet the FDA tells us for security, probability isn't what we should be thinking about. So we have this potential where we're saying the same words, but we're meaning different things. And then in terms of the ad hoc navigation and reliance on use cases, we think about how would you work through this system? You might work left to right, right to left, but that wasn't the only way in which people actually thought about it. They said, all right, I'm thinking about putting authentication here for the surgeon. Where else might I put authentication in my system? Oh, the observers, great, that's another place for it. So you're linking whatever you're working on to another part of the system in order to actually help you brainstorm. In addition to that, this idea of use cases, where you're saying, all right, I want to focus on how the surgeon is actually manipulating the robot. Where might I need to think about securing this part of the pipeline? How do I focus in on here? And we think this is something that really should be highlighted more because, again, we have this idea, and again, prior work has looked at data flow diagrams, which are the common thing used for threat modeling. They're not sufficient, and for instance, we see here that the use case is not actually something that is highlighted in a traditional threat model. Data flow diagram. So with that, what are our recommendations? So we want to accommodate this more natural process in tools. So recommendations for tool tool builders is this idea of free-flowing process through interaction, allowing for multiple configurations based on my customer's needs, use cases, this idea for prompting for multi-patient harm. So this idea like let's force people to think about safety explicitly, and then just generally thinking about integration with safety risk processes. For the FDA and other regulators, we think that you should be delineating between internal and external architecture. So these are the things that what are internally that I control that the customer can never change, and then what are the external things that might change that the customer should be aware of that could have security implications on their system if they misconfigure, et cetera. And then for researchers who are interested in studying threat modeling or medical device security, we've developed these scenarios, as I said, that are available to test frameworks, to think about realistic scenarios that we can look at how does this actually perform. So with that, I want to give a shout out to the rest of the research team, as well as big acknowledgments to the folks who helped us design and build this study, and also, of course, to our participants who helped give us these insights, and they were really great, wanting to chat more and more about what we're doing and how we're thinking about it. And also a big thank you to our funding from MedCrypt and Cisco. And just a note, so yeah, all the scenarios and code book, et cetera, are all found in our supplemental materials. But with that, happy to take any questions.